Well, hello, everyone. Welcome to our conversation here. My name is Corey Perlman. I'm the owner of Impact Social Media, a digital marketing agency that helps businesses grow their business. And today we are here with two very talented doctors to talk about an extremely important topic that I'm going to let Dr. Brown give some context for. But before we get going, I want to let you know who you are listening to and some of their credentials. So I'm going to start with Dr. Goff. We were just talking about the Ohio State University and that they happen to be playing a basketball game right now. So we will keep her focused on this meeting, and I'll send her text score updates from time to time. But Dr. Goff is an infectious disease clinical pharmacist with over 30 years of patient care and experience at the Ohio State University, Wexner Medical Center, and professor of pharmacy practice in the College of Pharmacy in her hometown of Columbus, Ohio, USA. Dr. Goff is one of 25 global health experts selected in the World Health Organization to implement antibiotic stewardship programs in low, middle income countries. She's a consultant to the Center for Disease Control and Prevention for dental antibiotic Periodontist in private practice, conducted a workshop with private practice dentists and orthopedic surgeons to address dental antibiotic prophylaxis in joint implant patients. Sorry, I'm a layman here, so the words are a little harder for me to read. Dr. Goff is the principal investigator on the first U.S. study with private practice dentists to assess antibiotic use and provide updated practical guidance on the use of antibiotics in dentistry. She speaks to dental study clubs around the U.S. She has over 150 publications, numerous grants, and lectures nationally and internationally on infectious disease. So welcome, Dr. Goff. It's great to have you here.
Thank you.
And I am very fortunate to also introduce my colleague and my friend as well, Dr. Brown. Dr. Brown is out of Philadelphia, Pennsylvania. He is a periodontist. And most importantly, I would say about Dr. Brown is I am most impressed with being named Philadelphia Magazine's top dentist for, I think we're on, is it 7 years running, Dr. Brown? Where are we at?
13.
Oh gosh, I kind of undercut you. So I can't go over 13 years, including this year in 2022 as a top dentist in the Philadelphia area. So congratulations, Dr. Brown. Dr. Brown spent his entire career expanding the knowledge of his discipline by embracing new technologies in periodontics and implant dentistry. He's been recognized nationally and internationally for his contributions to the art and science of periodontics. So Dr. Brown, welcome to you as well.
Thank you very much, Corey. It's good to be here, and especially good to be here with Debbie. I want to tell you that about 2 months ago, I was at a meeting of the North American Society of Periodontists in Columbus, Ohio. This group represents some of the most talented and creative and accomplished periodontists in the United States. And we had Debbie as our speaker. And I have to tell you that the message that she brought to us was so powerful that when I returned to Philadelphia, I completely changed my regimens for antibiotics in my office. She is a powerhouse, as you've already mentioned, and she has a great message to bring forward, which is a radical change in the way in which we see antibiotics in practice, clinical practice. Debbie, a question to you, and that is, you're in a hospital setting with many, many physicians, and you've lectured the world, all over the world on this topic. How did you get involved with working with dentists?
It's a great question, and I get asked that often. Well, my husband is a prosthodontist in private practice, and he had a patient. So this is a true story. He came home from work and said, I had a patient today, a woman who had a joint implant. She had her hip replaced 20 years ago. The surgeon was long retired. And before my husband was going to do the procedure, she said, I need my dental antibiotic prophylaxis. And he said, actually, there's new guidance on that. It's actually no longer recommended for everybody. Your implant was 20 years ago. You're not at high risk. And antibiotics have risks. And so the American Dental Association, along with the American Academy of Orthopedic Surgeons, no longer recommend dental antibiotic for lifetime for everybody. And the patient was totally confused and what I call stuck in the middle. Which doctor do I listen to? And no patient should ever be put in that scenario. But the patient was really conflicted and decided to not go on to have the dental procedure. And when my husband shared that story, as you stated, I work in an academic medical center working with physicians teaching responsible antibiotic use. I just said, this is not appropriate. The patient should never have to make that decision. And why are orthopedic surgeons and dentists giving conflicting recommendations to patients? There's national guidelines, and why aren't they being used? And I said, let's try to solve this. And that is how I entered into working with dentists. And so really, my husband was the main purpose because he shared a patient's story. And I never want to see patients harmed by being given unnecessary antibiotics, because antibiotics have risk. And that's the patient that I see, the ones that are harmed from antibiotics. They truly are life-saving miracle drugs when prescribed necessarily for procedures that actually need an antibiotic. But when they're prescribed unnecessarily, there are risks. And those risks include adverse events, and there are serious adverse events from antibiotics. So patients need to be aware, so do doctors, that antibiotics have been perceived for decades as benign drugs, risk-free, give more. So nobody wants an infection. That's correct. But 1 in 5 patients are actually harmed from an antibiotic. And that's a statistic I don't think most doctors know. And those are the patients that I see. So the definition of serious harm is an antibiotic where a patient develops an adverse event that requires a visit to a doctor, requires a visit to the emergency room, or actually hospitalization. And those are the ones that I see. And one of the most serious side effects of an antibiotic is the development of diarrhea that's called C. diff, Clostridium difficile diarrhea, that actually can result in the death of a patient. And most people don't know that, because if you prescribe an antibiotic because you think it's necessary and this harm occurs to the patient, they're not running to the dentist when they have this diarrhea and a fever and their abdomen is in pain. They run to the emergency room. So, I see that patient, and I've watched patients die from side effects from antibiotics, specifically C. diff. And so I would really encourage every dentist and patient listening, go Google Peggy Lillis, Lillis. The PeggyFoundation.org is a C. diff awareness organization. That woman was 51 years old and received an unnecessary antibiotic called clindamycin from her dentist, who prescribed it for a toothache. And I don't know the details of why the dentist did that, but I also know patients pressure doctors for antibiotics. And I think it's very common in dentistry. When a patient calls your office at Friday at 4 o'clock or 5 o'clock, because that's when those calls usually come in, and I have pain and maybe swelling or not, but pain alone is not an indication for an antibiotic, and that's per the ADA. But patients pressure dentists and doctors for antibiotics. But she received clindamycin, and 5 days later, she presented to the hospital and in 48 hours died from Clostridium difficile infection, which is the toxic form of this diarrhea that can be caused by any antibiotic and even a single dose of prophylactic antibiotic. So there are true risks, but I think the perception, because I see this in medicine all the time, when the doctor prescribing the antibiotic never sees the harm, why would you think that there's any risk in giving it? And so you have to understand the perspective of the person doing the prescribing. And that's really what I do, is I listen to why do you do what you do, and then create the facts of the consequences of antibiotics. So until you're informed of these harms, you continue to prescribe them because the perception is they're safe and effective for everyone.
I'd like to bring this down to a personal level because that information is astounding and was astounding to me the first time I heard it. I'm going all the way back to dental school where they scared the devil out of us with respect to, heart issues associated with former injuries and what we had to do with people with valve replacements and knee and hip replacements. I'm professor of periodontics at a dental school at Temple and professor of periodontics at Temple, the University of Pennsylvania, and director of the Dental Implant Center at Albert Einstein. And at all of those places, I'm involved in teaching students, and they do not have this information. So when we come out, we're particularly concerned about prescribing antibiotics, and if anything, we tend to overprescribe. And when I first heard you speak in Columbus, it brought to mind and brought to my attention that we've been looking at this problem completely wrong over the years. And that is the reason that I drastically changed what we're doing in our practices. And I've been preaching this to my dental students and my residents in periodontics at the three universities that I work at. So, Deb, what exactly is dental antibiotic stewardship? Sounds like a very impressive term, but help us to understand what that's all about.
Sure. So the word stewardship means overseeing something worth protecting. So what is that something? It's an antibiotic. So in medicine, we do antibiotic stewardship. Dentistry, it's called dental antibiotic stewardship. And it's the responsible use of antibiotics. And people go, well, of course, doctors would only prescribe an antibiotic when necessary. Well, stewardship is overseeing all prescribing of antibiotics. And why is it such an issue now in 2022? The world has run out of effective antibiotics. And I travel the world. I've been to 6 continents implementing these antibiotic stewardship programs. What changed about 15 years ago is antibiotic resistance started escalating around the world because pharmaceutical companies got out of the business of discovering new antibiotics. When I go back to the beginning of my career, the hardest part was keeping up with all of the new antibiotics. There was, I think, a new cephalosporin every week getting FDA approved. But now pharmaceutical companies figured out there's no money to be made in antibiotics. And so they got out of the business. I mean, they're not in the business, they're in the business of making money. And their vehicle to make money happens to be drugs. So antibiotics are a really dumb investment for a pharmaceutical company because the longer they are, and the longer we use them, and the more we use them, the less useful the antibiotic becomes because bacteria live to mutate and trick the antibiotic. I mean, look at what variant are we on now? Yeah. Viruses and bacteria are constantly mutating because their job is to stay alive. So bacteria always mutate. That's not new. But what changed about 15 to 20 years ago is pharmaceutical companies stopped discovering new antibiotics. So you put those two scenarios together, bacteria continuing to mutate, to develop resistance to the antibiotics so they can live, and no more new antibiotics, and you get the crisis we're in right now. I literally have patients at our hospital where I have no effective antibiotic to treat them with. And what happens? Many of them just die. I mean, when you have infections that are untreatable, people die. And so we are in a very dire state around the world. And so that's why these antibiotic stewardship programs came to be. We can't just let everybody keep prescribing antibiotics for everything they think is good. We need someone to really oversee the use of antibiotics. And it's not just in human medicine, it's also in veterinary medicine, in our animal feed. 80% of antibiotics in the United States are prescribed, or not prescribed, are given to animals, not humans. So when you think of that, that's called One Health antibiotic stewardship. So it's the impact of antibiotics in our animal feed, in our ecology. We spray apple orchards in our environment with antibiotics to prevent this fungus that develops on them. It's overwhelming when you think of how much tonnage of antibiotics we are actually exposed to without consciously taking them. So that's what antibiotic stewardship is responsible use of antibiotics. And you really need someone to be the leader of that. And that's what I do. So infectious disease experts in the hospital, physicians and pharmacists trained in infectious diseases oversee these programs. And once you teach the information, each prescriber, whether it be a dentist, a veterinarian, a physician in the hospital or an ambulatory care nurse practitioner, whoever the prescriber is, then becomes an extension of myself. I teach the principles of here's new information about responsible use of antibiotics, and you need each prescriber then to take ownership of that. And then you, as an educator, continue to teach that. So we help each other. And that's what an antibiotic stewardship program is overseeing the responsible use.
And as a result of that, we need to be your army out there, letting the patients know, letting our colleagues know what's going on. What I do know about you as well is that you and your colleague, Julie Mangino, conducted the first U.S. study with private practice dentists to evaluate prophylactic and therapeutic use of antibiotics in their practices. So tell us a little bit about what you learned from that study, because I think that's really important for both our patients and our colleagues to hear.
Yeah, so it was an amazing study to do with private practice dentists. So there are a couple of studies that have been published, but they're all in the VA system, which is a very controlled environment. It's kind of like working in the hospital. We can set up a guideline and you have to follow it if you are employed there. So, in private practice, every dentist can prescribe whatever they want. There's no oversight. So I thought, listening to my husband describe and many of his colleagues that I'm friends with, I thought, let's do this study with private practice dentists and see what they do. So it was a before-after study. We looked at all their antibiotic prescribing, prophylactic and therapeutic, in 2019 for 3 months. And we received a grant, so we were able to financially support their office staff to collect all of the antibiotic data. So we had the diagnosis and what antibiotic, the dose, the duration, if they were penicillin allergic. And we collected that in June, July, and August of 2019. And then we skipped the year of COVID. And then in March, April, May of 2021, we provided dental antibiotic stewardship guidance. So we gave 4 interactive discussions and really brought them up to speed on what the newer guidance is showing and what is the evidence of how they do things. And so we analyzed the results of how they were prescribing, and then we looked for the opportunities for improvement. How could we teach? What do we need to teach these dentists to do better? And so it was really compelling to us because there were many things we learned from the study. But what was really gratifying is how the dentist received the information. When someone tells you your appropriate prescribing of antibiotics based on what's published in the literature as appropriate is 10%, that's pretty hard to accept because everybody thinks they're doing what's best. But as we shared some of these new guidelines and new definitions of appropriate, because the literature is constantly changing, They were like you described as I shared the information at the meeting I spoke at. It's rather shocking that you didn't know this, but very willing to change. And that's what I find was so gratifying is we were able to change the prescribing habits to a higher level of excellence by giving these 4 lectures. And so then we did a post-education antibiotic data collection. So we collected all their prescribing after we educated them on the new guidance and our recommendations in June, July, and August of 2021. And it was so dramatic of the percent compliance with appropriate guidance up in the 90th percentile. And we're quite excited. We will proceed to publish that, but it has been accepted to be presented at our National Infectious Disease meeting next month. So we're really thrilled because we really want to engage more experts like ourselves to help teach private practice dentists these concepts.
And that's very, very important. But what I've learned over the years from my colleagues are they like to have bing, 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 bing. So could you give us a list of the top 5 antibiotic tips for dentists?
Absolutely. And
because they'll be listening to this.
Yes. So keep in mind, what I'm going to recommend is all evidence-based. We don't have enough time in the podcast to go through all of the evidence, but you've heard it and you know it's very convincing.
Absolutely.
Dentists should absolutely stop, effective immediately, prescribing clindamycin and the fluoroquinolones. The quinolones are ciprofloxacin, levofloxacin, and moxifloxacin. Dentists in the United States are the highest prescribers of clindamycin. And why is that? Because dental schools used to teach, appropriately so many years ago, if you have a penicillin allergic patient, the recommendation was to prescribe clindamycin. And back before we know what we know now, clindamycin is an excellent drug for dentists because it has a very broad spectrum of anaerobic coverage and coverage for some of the staph and strep species. So if you were pen allergic, it made perfect sense. And that's what was taught. What changed is that clindamycin is the number 1 cause of Clostridium difficile. So that's always been known. But what changed about 15 years ago is the C. diff developed a hypervirulent strain that caused this potential serious C. diff that can cause death. So many patients could develop C. diff from clindamycin, but in 20 years ago, you generally wouldn't die from it. It's very catastrophic to have C. diff. That's urgent diarrhea. So that's what changed. So the ADA actually took clindamycin out of the guidelines in 2017. And importantly, the American Heart Association has removed clindamycin from the guidelines in 2021. So there's no guideline-based support for dentists to prescribe clindamycin. And the recommendation now would be in your pen allergic patients, you can prescribe azithromycin, doxycycline, or in certain patients where their allergy does not include anaphylaxis or hives, Keflex, cephalexin. So you have 3 other options. So that would be my first recommendation. Next, I would say you need to use shorter courses of antibiotics. So we learned in our study, many dentists prescribe 7, 10, or 14 days for antibiotics. So when your patient needs an antibiotic, those were standard durations. They are not based on any evidence in the dental literature. And in medicine, we are down to treating hospitalized patients with community-acquired pneumonia for 5 days. So what I recommend to dentists, there is a new ADA guidance for patients with pain and swelling, where they now recommend 3 days of antibiotics and reevaluate. And if the patient's swelling has gone, they are to stop the antibiotic. So in a long summary of the literature that we've read through, our recommendation is, per the ADA, that one guidance, 3 to 5 days, and reevaluate your patient. We learned in our study every dentist prescribed durations exactly the same, no matter what it was they were treating. So if you're doing 7, 10, and 14, our recommendation is to change that to 3 to 5. There will always be patients that are exceptions to the rule, but in general, your go-to duration should be 3 to 5, not 7, 10, and 14. And then I would recommend for penicillin allergic patients, do your patient a service by recommending them to go see an allergist to get desensitized to penicillin, because they're now being used second-tiered antibiotics. And we always want to use the drug of choice, which in dentistry would be amoxicillin. And so desensitizing them to penicillin is a really good recommendation. And you can make that recommendation. And then I would also recommend using shared decision-making in those joint implant patients. There is a new study that really puts to rest the need for joint implant antibiotic prophylaxis. It's a new study just published in a prestigious medical journal called JAMA. But the problem there is orthopedic surgeons read orthopedic surgeon journals. Dentists read dental journals. This is in a medical journal. So I think it's going to take a while for both groups to find this. But it's an amazing study of over 9,000 patients in the United Kingdom, where they were hospitalized for joint implant infections, and they looked at the relationship to a dental procedure, and they could find no association between dental procedures and the development of a joint implant infection that required hospitalization. So it puts to rest the need for prophylaxis in all patients. So that study, I think, is very important. So using shared decision-making with your joint implant patients is so important. And it's endorsed by the ADA. So when you have a patient that says, no, my orthopedic surgeon told me I am to take antibiotic prophylaxis, and you're recommending they do not, explain to the patient the risks. Are you aware of the risks of taking an unnecessary antibiotic? And after you explain that to them, and I have a diagram that you can use, then you have the patient sign that. Which one would you like to do? Do you want to take the antibiotic to prevent a theoretic joint implant infection? Because there's no guarantees. So there is a 1% chance a patient can get infected, but the literature shows it's not related to the dental procedure. Or do you want to not take an antibiotic, or do you want to take an antibiotic? And 1 in 5 patients will actually have harm. They can have microbiome disruption, they can develop the C. diff infection, or they can have other adverse events. And the patient, after they're informed of the risk and benefit, can make that decision. And that's what shared decision making is. And if they decide, I want to take the antibiotic prophylactic, have the orthopedic surgeon write the prescription, because you're really putting yourself at a very high risk. If harm does occur to the patient, they develop C. diff. We do know patients sue doctors all the time. The doctor who will be sued for an antibiotic adverse event is the doctor who wrote the prescription. So it is not supported by the ADA or the American Academy of Orthopedic Surgeons to prescribe dental prophylaxis for all patients any longer. So if the patient insists, then the orthopedic surgeon needs to write the prescription. So those were my 5 really take-home tips for a dentist to stay abreast of the new changes. Remember, in infective endocarditis, that does require antibiotic prophylaxis, but there are only 4 indications. So those guidance have changed. So you do need to go to the American Heart Association or the ADA website and make sure you're abreast of the recommendations for infective endocarditis. So that is something that does require prophylaxis, unlike the joint implant patients.
I know of a colleague who had a patient, had that antibiotic, ended up in the hospital for over a week with C. difficile. So it's real. And it's something that we all need to be really aware of.
Yes.
I will also say that as a result of your influence and the information that you gave to us, whereas we used to routinely prescribe amoxicillin to a patient having a surgical procedure for at least 5 days.
Mm-hmm.
At your recommendation, we have now completely eliminated that. We are giving the patient 2 grams of amoxicillin about an hour to an hour and a half before the procedure, and no additional antibiotic after that. So that's been a big change that we've made, and we've seen really good results as a result of that. We've seen excellent. Tell me about what can we do to spread the antibiotic guidance to the rest of the professional world that we come in contact with?
Sure. Well, I think what we're doing today is a great service to all of your peers, because this is how it's going to be spread. And just lecturing, you guys have this amazing network of dental study clubs that are well established across the United States in all disciplines. So I think as more of you are becoming experts in this area now that you've learned this new information, you just become an extension of myself, and you continue to spread that message to as many dental study clubs that you possibly can. And I think this is one amazing example of how you're going to do this, because you're right. Every dentist needs to know this, but I also know when you're running a busy practice, and you're not in academic medicine, this is my job. I have to stay on top of the literature constantly in infectious diseases, because I'm responsible for teaching this to our 1,400 patients that we care for at Ohio State. And antibiotics are a necessary part of our job, but we can all do better. And so there's not just me in our hospital, there's many of us teaching this message. And so I call the antibiotic stewardship experts in infectious diseases. We steer the ship, but you need all hands on deck, or you're never going to get to the end of the journey. And the end of the journey is responsible antibiotic prescribing. And that includes consumers. As a dentist,
sure.
How many patients have told you, oh no, I always get an antibiotic when my tooth hurts. I absolutely need an antibiotic if you're going to extract a tooth. That's part of educating patients. They are part of this picture. They need to understand there are serious risks. So I always go back to the Peggy Lillis story. She was prescribed an antibiotic, and when she died, her young son came into that hospital and they said she's gone. He thought she meant gone for a procedure. And no, the doctor meant she just died. And so he could not comprehend that his mother died from a, quote, benign antibiotic, right? But that was the truth. He never knew you could die from diarrhea, but you can.
Well, I will tell you that you're creating an army of we dentists, because you are indeed correct that we have study clubs and groups that we join. In my case, and some of the others of my colleagues, we teach at various institutions. So little by little, and the stone is rolling quicker and quicker, we're getting the word out to people. So
we want that stone to become a boulder, and that's what you're doing. As it keeps rolling, it keeps picking up more and more dentists, and you get more people like yourself who are in a position of authority. You're well respected. You have years of experience. I'm not a dentist. And so I need someone with your credentials that can spread this message. There's nothing better than learning from your own peers that you respect.
Absolutely.
And so I acknowledge that I am not a dentist, but I am an expert in this area. And so it's been, I joke with my husband, I think I've read more dental literature than you, because I'm never going to get in front of a group of experts without thoroughly knowing what is in their literature. And that is part of the problem. The dental literature really is very inadequate in terms of studying duration of antibiotic therapy. And so it becomes someone like yourself that it's important for you to share with me as you change your practice and you now just give amoxicillin prophylactically. You're not giving this 5 extra days. Do you see any failure? Do you see, and yes, everybody fails an antibiotic. That's just the way it is. But you're going to be able to pick up if there's an issue. And so that becomes real important as I share with dentists and you spread this message to your colleagues and they start changing their behavior. You really create an amazing opportunity for a dental study, actually. And that's the academic side of me is I want to study to prove that this change didn't create harm, because that's why people are hesitant to change. And so I think it is amazing to get your feedback 6 months into this. And that's what's beautiful. The dentists that participated in our study a year ago at this point, I constantly am in touch with them. Have you noticed any change now that you're down to 3 to 5 days? Debbie, I haven't had anybody come back. So I really do believe we're providing great guidance.
Ditto me on that one.
Thank you. I love that.
Absolutely, because it's been a fantastic change all across the board. As a matter of fact, the most difficult thing is to get the patient to understand, because they've been brainwashed to have antibiotics a certain way.
Right.
But it's the acceptance rate has been really fantastic. So are there resources available for the average patient to become better informed about the use of antibiotics, other than we clinicians telling them what we've learned?
Yeah. So actually, if patients can Google CDC dental antibiotic stewardship, or you can just Google CDC antibiotic resistance. The CDC does an amazing job with patient education, and they have specific categories for patients to understand the risk of antibiotics. And they create what are really called infographics, like here, well, probably can't see this, but they have pictures of, 1 in 3 antibiotics prescribed are not necessary. So why are doctors prescribing them? Because the patients demand them. And if you don't give it to them, when they leave that urgent care visit, they go on Yelp and give you a horrible review. And your reputation is real important when you're in practice. Who wants to be said that they were a terrible doctor? Nobody wants their reputation destroyed. And so patients need to realize there are real risks in taking antibiotics. And the risk that is hard for people to understand, every antibiotic we take, whether it's necessary or unnecessary, increases antibiotic resistance. That's just a fact. So imagine life without antibiotics. Imagine the 20-year-old having her first C-section, delivering her baby. She has a high risk of dying from the C-section if she does not have the ability to take a prophylactic antibiotic before the physician makes that incision. So there are, any surgical procedure you have, your appendix ruptures, the surgeon needs to give an antibiotic prophylactically, because that incision alone, you're cutting through and injecting bacteria into your body that you will die from. So we need antibiotics to be available that still work. Every one we take, every single one we use just keeps increasing antibiotic resistance. So there's a societal component to this.
Absolutely. So in summary, what would you tell us that we can do on an individual basis, both with our patients and our colleagues, to get them on board with these new recommendations, because it's life-saving?
Yeah. So I've asked every dentist I've lectured to, what would your recommendation be to have this information rapidly? You can't wait 3 years from now. So if you say, speak to the ADA, that's great, but those meetings and speakers are formed 2 years in advance. What do you do today? Well, what you're doing right now. this will reach many people. So a dentist listens to this podcast and says, or to the video and says, oh my gosh, I need my partners to hear this. And they tell them to listen to it. You write a newsletter and share that with your staff and news patients. And then dental society meetings in the state of Ohio, opioid lectures, opioid education is mandatory to renew your dental license. You have to do
Pennsylvania as well.
So it's not in every state, but in many states, you have to have a 1 hour CE on opioids. I had several dentists in our state say, dental antibiotic stewardship, what you just taught us, Debbie, should be mandatory. And when you sit and think about it, once you've changed your use of opioids, as some of the dentists said, I don't need to really hear an opioid lecture every year. I no longer prescribe them like I used to, and nothing really changes. So they've learned and they've changed their behavior. But what antibiotic you should use, that's going to constantly keep changing because we learn new information. They've said we should go to our state board and recommend a mandatory dental antibiotic stewardship lecture each year. So that, I think, is a brilliant recommendation. And if it requires, a year's worth of, paperwork to make that happen, then piggyback it on to the opioid lecture, because that's really opioid stewardship. It's the same concept. You're stewarding the appropriate use of opioids to prevent harm in your patients. So now just take the opioid required CE and give a half hour to antibiotic stewardship, because it's really stewardship of two very important drugs, opioids and antibiotics. I think that is a brilliant recommendation.
Well, Debbie, thank you very much for bringing all this information to us. I can tell you on a personal note, you changed my life with respect to my practice and my patients, and they are the better for it. And I will be one of your disciples out there speaking to my students, my residents, and my patients about this. It's information they need to know, and you have brilliantly presented it. So we thank you very, very much.
I appreciate that. And thank you for this.
Yes, Dr. Goff, I just want to say as the sort of the layman of the group here, just listening, this was eye-opening for me. It was intense, hearing about that story of her. And I have a personal story of my own family who she was prescribed antibiotics and went through hell, literally what you're talking about, just almost ruined her life completely, double hip surgery, so on and so forth. And it could have not, happened based upon, I think, what she was prescribed. So this was definitely near and dear to my heart. So thank you for all of that valuable information, both to dentists out there, but as well as the patient side. And Dr. Brown, just a shout out to you, man. You are always adding this value to your colleagues and to your community. So constantly wanting to educate not only yourself, but others, which I just think is fantastic. So thank you both so much.
Thank you as well.
All right. Well, everybody have a great day. And we hope if you like this, please share it, spread the news. Let's create a movement. Let's make that boulder bigger and bigger and bigger. So thank you so much. And we'll see you again real soon. Take care, everybody.
And go OSU.
Yes. Hopefully they're winning right now.
All right.